Hello students, myself Prathyankara Prasad, Assistant Professor, Department of Respiratory Therapy, School of Allied Sciences, Vinayaga Mission Research Foundation. So now we are going to see about tuberculosis, a comprehensive clinical guide. As you all know, TB is caused by the bacteria. Bacteria name is Mycobacterium tuberculosis. To know about tuberculosis, we have to know about what is Mycobacterium tuberculosis. The main key characteristics of Mycobacterium tuberculosis are, it is acid-fast bacilli. What is acid-fast bacilli? First of all, it resists the staining procedure in all common stainer in the culture. So we are using Zeal-Nielsen positive stain for this particular TB bacteria with the characteristics of red staining against the blue background, and it is obligate aerobe which will grow in an oxygen rich environment, and it is a slow growing bacteria. The generation time is about 18 to 24 hours, requires the prolonged culture period for about 2 to 8 weeks, and it also has the characteristics of intracellular survival which is persistent within the macrophages by preventing the phagolysosome fusion and resist killing mechanism. So these are the main key characteristics of Mycobacterium tuberculosis. And moving on to epidemiology. In India, we are having the highest TB burden globally, and the drug resistant concern is increasing day by day. Transmission. The mode of transmission is very important in the case of tuberculosis. It is an airborne disease which is also spread by your air droplets, means respiratory droplets. In one cough, the 3000 bacteria will cause in one droplet, and in one sneeze, 10,000 droplets of bacteria will be transmitted. And in status TB in India is, in 1962 we introduced a national TB program. In 1992 program review have been done. In that review only 30% is diagnosed and 30% were treated. In 1993 national tuberculosis control program will be introduced in the India, which is begun in the 1997, which is a full-fledged program as started in 1997. In 2006 the entire country is covered under this RNTCP, National Tuberculosis Control Program. R means the revised National Tuberculosis Control Program. So this is the main status of TB in India. And to know about the global epidemiology survey taken in 2016, the key statistics shown is 10 million people were the incident cases, and 1.7 million deaths are there, and 600k people are under the MDR. That means multi-drug resistant tuberculosis. And what are all the types of tuberculosis infection? The first type is primary TB. Primary TB means which is the initial infection which causes your gone focus and gone complex. Gone focus means infection occurred in the lung parenchyma. Gone complex means infection got occurred in both the gone focus and the hilar lymphadenopathy, which involves mostly in the lower or the middle lobes due to the better ventilation. And next is latent TB. Latent TB means there is no symptom but there will be a positive IGRA test. Due to the immune control thing, the infection will present without the clinical feature, but there is a positive tuberculin skin test or IGRA with the normal chest radiograph with the risk of reactivation throughout your life. So what is secondary TB? Secondary TB is a reactivation TB which has your apex predominant disease with the cavitatory lesions due to reactivation of a dominant bacilli, which characteristics is more appropriately in the upper lobe and more appropriate infiltrates in the upper lobe and cavitation on the imaging. And what is miliary TB? Miliary TB is nothing but a disseminated disease with the hematogenous spread, creating the innumerable small nodules throughout the both of your lungs, which resembling the millet seeds on the chest X-ray. So what is extrapulmonary TB? Extrapulmonary TB means which affect the region other than the lungs, which means affect your lymph nodes, your nervous system, your spine, pleura or genitourinary system or gastrointestinal tract, which termed as the TB meningitis or pod disease or the pleural effusion TB diseases. So these are the basic types of tuberculosis infection. So now I will give you the cases. Let me know if you guys understand what are all the types of the tuberculosis. What if the TB occurs in your upper lobe? Only upper lobe activation is there means, which just mean it is a secondary TB. If there is multiple millet seed appearances in the X-ray means it is mean miliary TB. If there is no symptom but there is a positive sign in IGRA test or tuberculin test means which is mean by latent TB. So what happens when first TB enters your body? When first that Mycobacterium tuberculosis enters your body? First, the bacteria will get inhaled into your lungs. The bacilli will reach us in the alveoli, and there macrophages will create phagocytosis. Bacilli will prevent the phagolysosome fusion, which get multiplied by the lymphatic spread, and in there your cell mediated immunity will get started to act within 2 to 8 weeks. There your Th1 response and CD4 T cells response and your alpha interferons response will take place. After that, granuloma formation of the wall of bacteria, casseting necrosis, which is a cheesy structure in your lungs, and Gonfocus and Langerhans giant cell will get formed. Together, your Gonfocus and lymph node is known as the Gon complex, which will undergo the fibrosis and calcification and formed into a scar tissue, which is also known as the Ranke complex. I will show what is the Ranke complex look like. And this will divided into the two things. One is a clear infection and another one is a latent infection. Clear infection means primary infection. Later infection means which has no symptom. So it has a memory cells, it can be reactivated in your future. I have already told about the miliary TB. If that affects your brain, it is known as meningitis. If that affects your heart, it's known as pericarditis. If that affects your spine, it's known as Pott disease. This is how the Ranke complex will look like. Ranke complex will look like this. Gonfocus. Gon complex and Gonfocus are moreover the same thing, and Ranke complex is also similar to that thing. What are all the important clinical features of the TB? Chronic cough, hemoptysis means your blood streaked with sputum, and fever with the characteristics of evening rise and drenching night sweats, progressive weight loss due to the loss of appetite, and chest pain and dyspnea. These are the primary important clinical features of TB. And extra pulmonary manifestations of in lymph nodes, painless and maternal nodes with the cold abscess formation will be there, and if that affects your CNS, central nervous system, TB meningitis with the basilar meningeal enhancement and hydrocephalus will be present there. And if affects your spine, this is known as the Pott disease with the vertebral collapse and the paravertebral abscess. If that affects your pleura, which gives you the exudative effusion with a lot of bacterial things, with the report blood test we can identify that with the lymphocyte and predominance. Which patient must be investigated for the TB under National Tuberculosis Elimination Program? If the patient have fever for more than 3 days, we have to treat the patient in the case of TB. If the patient has cough for more than 1 week and cough for more than 2 weeks and in combination with the chest pain means we have to treat the patient in the cause of TB. So basic tuberculosis symptoms are: one is fever, it will be happen more than 1 week, and fatigueness and weight loss due to the loss of appetite, and persistent cough more than 2 weeks, and blood in your sputum, which is a hemoptysis will happen, and night sweats. The diagnostic approach which got updated by the year of 2024 to 2025 is: first, the gold standard test is CBNAT, Cambridge based nucleic acid amplification test, which is the first line test which detect the TB DNA and rifampicin resistance simultaneously, which is very important to control your drug resistant cases. And sputum smear microscopy by the culture of with the help of the culture of Zeal-Nielsen staining, and your culture is also a gold standard requiring for 2 to 8 weeks for the drug susceptibility testing, and line probe assay which detect the resistant to the all of your drug like rifampicin, isoniazid and the fluoroquinolones. And your chest X-ray findings are: in chest X-ray you can see the upper lobe infiltration, cavities and fibrosis and lymphadenopathies. In HRCT you can see the tree bud pattern and centrolobular nodules and cavitation and bronchiectasis and superior sensitivity for earlier complicated cases. And by third, immunological testing are Montauk, which is a tuberculin test, purified protein derivative skin test for screening. In duration is more than or equal to 10 mm, considered a positive in the high risk population. And IGRA, interferon gamma release assay, referred for the latent TB specifically, especially in the BCG vaccinated populations. And these are the main thing, and most predominantly we are using this Montauk tuberculin test. 0.1 ml of 5 tuberculin units of liquid tuberculin are injected between the layers of skin and the forearm. Forearm should be examined within the 48 to 72 hours in that patient. The reaction in that area, that means swelling or inflammation that will happen in that area, that in duration is measured in the millimeter. With that we can conclude whether the patient have tuberculosis or negative for the tuberculosis. You suspect TB, what is your first diagnosis will be? your first diagnosis should be CBNAT, which is the gold standard. The full form of CBNAT is Cambridge-based nucleic acid testing. And treatment regimen for tuberculosis. First line, there are two things. One is first line treatment and another one is second line treatment. First line treatment is especially for drug susceptibility TB. And isoniazid, there is a regimen name of HRZE. H for isoniazid, bactericidal, inhibits mycolic acid synthesis in the bacteria. And rifampicin, bactericidal RNA polymerase inhibitor, and pyrazinamide, bactericidal in the acidic environment, and ethambutol, bacteriostatic cell wall inhibitor. And in recent time, in the recent update, ethambutol is not using by the clinicians. And what is DOTS? DOTS is the program which is very important in the case of tuberculosis. Full form of DOTS is directly observed therapy. To eradicate TB completely, the patient need to take the drug for the complete cycle of 6 months. To observe the patient for that complete 6 months, we have to undergo this DOTS. So DOTS stands for directly observed therapy. Short course, a tuberculosis control strategy recommended by the WHO. It is the most cost-effective way to stop the spread of TB in the communities with high evidence by ensuring the patient complete their treatment and preventing the development of the drug resistance. So these are the strategies that consist of 5 key components that comes under DOTS. Government commitment with political will and sustainable financing. Case detection through the quality assured sputum smear microscopy. Standardized treatment with a short course regimen, which is DOTS, that HRZE regimen, typically for 6 to 9 months, directly observed by the healthcare worker or the community health worker, especially during the initial incentive phase. And a reliable drug supply system to ensure the uninterrupted access to the quality medicine. A standardized recording and reporting system to monitor the treatment outcome and program performance by the patients. Directly observed treatment short course, DOTS. There are 2 types of phases in that. One is the intensive and another one is continuation phase. The first 2 to 3 months is known as the intensive phase. Other 4 to 6 months is known as the continuation phase. In first 2 to 3 months, the patient will undergo the direct supervision of the healthcare worker or the clinician or the trained person. Another continuation phase will be under the supervision or by the family over the person close to the patient can supervise the patients. A multi-blister combi packed with drugs for 1 week is given off, which the first dose is taken under the supervision. Another dose can be taken under the supervision of the family or the friends or the person who is close to the patients. Role of respiratory therapist in TB management. As this is respiratory condition, the role of respiratory therapy is very important. The first thing is the airway clearance, airway management. Postural drainage, draining your lung if the TB present in the pleural region and all, it is very important for the patient to get postural drainage. And chest percussion to loosen your mucus. Your thickened mucus will get loosened by the use of chest percussion. And vibration technique and incentive spirometry, which is very important to enhance your respiratory muscle and to develop the patient from the condition and to recruit the alveoli. To prevent the atelectasis. Sputum induction procedure when spontaneous expiration is inadequate. Another thing is infection control. Infection control by the use of N95 respiratory fit testing and monitoring and ensuring the negative pressure room functionality. Patients should get isolated from the normal patients. Airborne precautions including the door closure and limited room entries and environmental monitoring should be happen. Monitoring and support. Oxygen therapy titration with pulse oximetry and ABG result is needed for the patient by the morning and the evening rotations, and ventilator management in the severe case of TB and ARDS, and capnography monitoring for the respiratory status assessment. Capnography is nothing but monitoring the patient's CO2, end-tidal CO2, ET CO2 level. And pulmonary rehabilitation. For every patient who undergoes a respiratory condition need pulmonary rehabilitation to recruit and go back to their normal life. In TB and all, the patient will get severely affected from their normal life. To get back to the normal life and to live their normal condition, pulmonary rehabilitation plays a very good vital role. So exercise training program for the post-TB treatment and breathing exercises for the patient with the help of diaphragmatic breathing or pursed lip breathing. This is very important. And patient education on the airway hygiene and long-term follow-up for the post-TB lung conditions are very important. And infection control reminder, patient remain infectious until 2 to 3 weeks of effective therapy and sputum smear conversion. Respiratory isolation need to be there until the non-infectious status is confirmed to the patient. And National TB Elimination Program, we have already seen in the epidemiology slide, National TB Elimination Program and recent advancement by the NTEP. NTEP goals are Indian commitment to eliminate the TB by 2025. But in 2025, there is no elimination of TB till now, but they are planning to eliminate the TB by 2030 at least. So, Nikshay portal for the digital case-based surveillance as introduced by the government, and direct benefit transfer for the nutritional support also be done by the government. And key strategies are active case findings in the vulnerable population, daily treatment regimen replacing the intermittent dosing, and patient-centered care with the nutritional support and digital adherence monitoring via 99 dots technology. These strategies will be handled by the government under the NTEP program. And recent advancement in the NTEP programs are 6 months MDR TB regimen replacing 18 to 24 month therapies. They are reducing the treatment course period. All oral regimens eliminating the painful second line injectables. They are replacing the injectable with the oral regimens, and rapid molecular diagnosis reducing the turnaround time from weeks to hours, and AI based prediction models for the treatment response and adverse event monitoring, universal DST drug susceptibility testing, ensuring the appropriate regimen for the treatment initiation. And clinical pearls are suspected TB warrants CB NAT testing first and confirm the diagnostic before the initiating HRZE regimen, and check the resistant pattern and shift to the MDR regimen if needed. Prioritize 6-month oral regimen for DRTB, drug resistant TB, with the strict adherence monitoring throughout the DOT or NTEB. So the main thing is first diagnosis and confirm the case with TCB NOT or IGRA or tuberculin test. After that we have to go into the HRZE regimen. And direct benefit transfers from the government side are Nikshay Poshan Yojana. They are giving 1,000 per month to all the TB patients throughout their treatment period. And tribal patient incentives are 750 rupees to all the tuberculosis patient in notified tribal areas. And treatment support honorariums and private provider incentives are private practitioner notifying TB patients given 500 rupees at the time of notification and 500 rupees at the time of treatment outcome. And informant also getting the incentive to hand over the patient to the government for the treatments. To know about the TB, TB is not only a condition which is caused to the only poor peoples. It will also be caused to the celebrities, and these are 3 to 4 celebrities that are affected by the tuberculosis. But we have the stigma and thought that we have a myth that TB is only caused to the poor peoples and we are isolating them. But that is not true. TB is also be affected to all the celebrities and all kind of people. So people also suffer discrimination, stigma, rejection and social isolation in the case of TB, but that is a wrong thing. We have to treat them, we have to counsel them, we have to give them a rehabilitation. Not only a medicine can treat the TB patient, but also taking care and giving them a counseling and giving them a rehabilitation course, recruit the patient and get back their normal life. And March 24th is observed as a World Tuberculosis Day. As you all know, by the WHO, with the theme for 2026 is Unite to End TB and Leave No One Behind. So the take-home message is, main thing is, never start TB treatment without the microbiological confirmation, which is CB NAT, and also check for the resistant earlier, which will reduce your short course or which will reduce your treatment time. Thank you for watching my class.